G'day everyone, welcome to part one of this two-part lecture series on return to sport, ACL injury and rehabilitation, and the mental side of going back to sport. My name's Clare Ardern. I'm Senior Researcher in Sports Medicine at Karolinska Institute in Stockholm, Sweden. My research there focuses on understanding the factors that influence returning to sport and developing interventions that you can put into your clinical practice to help athletes return to sport and achieve their return to sport goals. I'm also the editor-in-chief of the Journal of Orthopaedic and Sports Physical Therapy, so I'm looking forward to sharing with you some of the ways that we as a journal and other journals are helping to translate the research that we publish into things that are helpful to apply in your clinical practice. So thanks for taking the time today. In part one, we're going to focus on the physical side of returning to sport. Part two in this series is focusing more on the mental side of returning to sport. So let's get into part one. We've got 4 learning objectives for this session. The first is that you will, by the end of the session, be able to explain the overarching goals of treatment for an ACL injury. Now, I appreciate some of you might be really experienced working with athletes with an ACL injury, and some might be newer coming to this area of rehabilitation and area of practice. So I want to start by getting us all on the same page and share what my take is on our overarching treatment goals. Then we're going to look at specific goals of rehabilitation. So you'll be really confident to describe what those goals are and how you're going to plan for your rehabilitation to address those goals. You'll feel really confident about sharing information, accurate information from research and from clinical practice with athletes, and to support those athletes when they're making return to sport decisions. And finally, you'll feel really confident to use your excellent clinical reasoning skills to develop sport-specific assessments to assess when the athlete is physically ready to go back to their sport after an ACL injury. Now, I've divided the session today into 3 major sections. So we'll look at the treatment goals first up, then spend a bit of time talking about return to sport and how our views on return to sport have evolved, particularly how the research has evolved, I think, to catch up with what you'll be familiar with in clinical practice. And then finally, I'd like to share 4 questions and then 4 key facts about returning to sport after ACL injury and ACL reconstruction that I believe are really important to share with athletes and that I think can help form a cornerstone of your return to sport planning. So let's first look at our goals for managing ACL injury, and I would respectfully suggest that there are really, when it comes down to it, 3 key goals. The first is to, above all, protect the meniscus. So we want to try to keep that meniscus healthy and avoid new injuries occurring to the meniscus. Quadriceps strength is critical to outcomes, so we really want to focus on restoring quad strength and building quad strength. And our final goal is going to be healthy sports participation or physical activity participation throughout the rest of the athlete's career, but into the rest of their lives as well. This is something that is going to be relevant across the lifespan. So we want to help that athlete have long-term healthy participation in whatever sport or physical activity he or she wants to do. Now, I want to start this session by busting some myths that I suspect might resonate for you. There's some common beliefs out there that athletes might come to you and share these beliefs, and I think it can be really helpful if you've got some research evidence to support the information that you're sharing with athletes when athletes are trying to make the best decision for their treatments. So I often hear from athletes that they feel like they must have surgery to fix their knee when they've got an ACL injury. I often hear, and you might have heard this as well, that athletes believe they've got to have an ACL reconstruction because that's the only way to get back to their pre-injury sport. You might also have heard athletes say, look, I can't afford to wait. I've got to have surgery immediately. That's the thing that's going to get me back to my sport. You might also have heard athletes say that they believe surgery is going to stabilize their knee and stop them getting osteoarthritis in the future. So what I'd like to do is take a little bit of time now to walk through each of these myths, each of these common beliefs, and share what we know from the best research evidence about how true these beliefs are. And this is really about empowering you to share accurate information to help athletes make the best treatment decision for them. Now, our first common belief is athletes saying, I've got to have surgery, it's the only way to fix my knee. Now, we've got one really important landmark randomized controlled trial that I'd like to share with you, and it's going to recur across a couple of these common beliefs that athletes might hold about managing ACL injuries. Now, what the researchers did in this randomized controlled trial is to take about 120 athletes who were young and participating in the cutting and pivoting sports that we typically associate with ACL injuries. So this is important because these are the athletes who we would typically expect to be wanting to get back to high-level sports. They're the typical ACL population. And they all had acute ACL injuries. Now, in this randomized controlled trial, the researchers allocated randomly half of the patients to get an immediate ACL reconstruction and the other half of the athletes, or the other half of the patient group, to start with a rehabilitation program, a really intensive, high-quality rehabilitation program, and then wait for some time to see if they had recurrent knee instability. Then they had late ACL reconstruction, but only if there was recurrent knee instability. And then the researchers followed these athletes or these patients for up to 5 years after the reconstruction. There was a 2-year post-operative key follow-up time and 5 years as well. Now, the critical thing here, when we talk about the common belief that surgery is the thing that's going to make the athlete's knee better, the key result from this randomized controlled trial is the self-reported knee function. And this was assessed using the KOOS questionnaire. Some of you might be familiar with the KOOS. It's a really common patient-reported outcome that's used in a whole bunch of knee injuries to measure the outcomes, patient-reported outcomes after knee injury, including after an ACL reconstruction. And what you see in the graph here is there were ultimately three groups in this trial, because we had patients who had an early ACL reconstruction. They're the ones in the open circles. We had a group of patients who had started with rehabilitation and needed to have a reconstruction later. They're the ones with the yellow, represented by the yellow triangles. And then we have the patients who never had an ACL reconstruction. They had rehabilitation alone, and they are the closed teal-coloured circles. And you see that there's some differences in particularly the first year after the ACL injury, and we would expect that. We would expect that people are at different trajectories here because some of these patients end up having surgery at different points in time. So that's why it's really important to look at the outcomes at 2 years after the original ACL injury was diagnosed. And what we see there is really striking, that it doesn't seem to matter what kind of treatment people got. They rated their knee function identically. You see all of those circles, triangles are overlaying each other. So it is possible, irrespective of the type of treatment people have, that their knee function ends up being just as good 2 years later. So that's not to say that there aren't people who need to have an ACL reconstruction. Clearly there are, particularly those who have recurrent knee instability. But this idea that everybody's got to have an ACL reconstruction to fix their knee is just not borne out by the best quality research evidence that we have. The second common belief that athletes have is that they need to have surgery to get back to their sport. And these are data from the same randomized controlled trial, so they're the same patient population. So what we know already is that they all rated their knee function exactly the same at 2 years, which is really important when we come to talk about return to sport outcomes. Because if people were rating their knee function differently at 2 years, and then we were also assessing their return to sport outcomes at 2 years, we might expect that their knee function being different could explain returning to sport. So the good thing about this trial is that at 2 years, when we first start to look at the return to sport outcomes, everybody's rating their knee function the same. And what we also see at 2 years is that the return to sport rate is also very similar. So it didn't seem to matter whether people had an early reconstruction, whether they had never had a reconstruction, their return to sport at 2 years was very similar. Statistically, there were no differences across these different percentages. I realised that they look a bit different. They're not exactly the same like the return to the self-reported knee function was, but these are similar enough for us to say that it doesn't seem to make a difference if you have what kind of treatment you have for the return to sport outcomes at 2 years. Now you might be thinking, okay, but let me see later on. Maybe it changes after a while. And here are the return to sport data, or actually sports participation data at 5 years after the ACL injury was first diagnosed. And here it's absolutely no different. There are 1 out of every 5 patients who are still playing their pre-injury sport at 5 years after their ACL injury was first diagnosed. Now you'll remember from a few slides ago that these were really highly active young adults. They were playing cutting, pivoting sports. They were participating at a really high level, and a lot of them are not participating in that sport. Almost all of them are not participating in that sport at 5 years. These data don't tell us why people are not playing their pre-injury sport at 5 years, and it might be that they've changed sports or they're doing something different. But the key thing about prognosis for you to share with newly injured athletes is that it doesn't seem to matter what kind of treatment they get for their return to sport outcomes. The third common belief people have is that I can't afford to wait. I've got to have an immediate ACL reconstruction because I need to get back to my sport. I've got a season to finish, or I've got one last season left in my career, and then I'm going to call it quits. What I would really encourage you to do is to look at the best quality rehabilitation programs, and here's an example of one. And what they share in common is this prehabilitation phase. So this early rehabilitation before making a decision about surgery. And it seems the data are relatively sparse. We don't have a lot of studies studying the effects of prehabilitation program. But what we can say is the studies that have looked specifically at the effects of a prehabilitation program, the results at 2 years later, results for self-reported knee function, are superior to athletes and patients who have an early ACL reconstruction without doing prehabilitation. So my suspicion is that prehabilitation gives the athlete a bit of a chance to experience what rehabilitation is like. And I think biologically there's a plausible rationale to say that if you do a really good rehab program before you make a decision, then starting off, whether your decision is to continue with rehabilitation or whether your decision is to have a reconstruction, that getting that knee into as good function as it possibly can be before you then jump into surgery is only going to be helpful, not harmful. So you see here, this is an example of what we now consider as the gold standard ACL rehabilitation program, with a prehabilitation period of ideally 3 months, minimum 3 months, heavy strength training, lots of really high level function training. Then we might choose to have ACL reconstruction, which is followed by our typical acute phase addressing impairments, focused rehabilitation, moving to more strength focus, and then finally focusing more on the sport-specific demands. And you see some of the key metrics or the key goals of each phase there. The other thing that Rehabilitation allows you to do is to build up that trust and rapport relationship with athletes, that we know some of these intangible kinds of things also play a role in a rehabilitation program. So building the trust relationship will help you with your shared decision making. You'll hear a lot more about shared decision making in part 2 of this series. We're going to touch on it a little bit today. We're going to touch on this idea of building confidence. You'll hear a lot more again about that in lecture 2. All of these sort of intangible things that we do without necessarily thinking specifically about what we're doing in rehabilitation, these are all part of a really good quality rehabilitation program that's going to give your athletes the best chance of succeeding. So I would encourage you to have a look at some of the literature in this field. They all talk about things that you can do to support athletes to feel confident during their rehabilitation program. They encourage you to collaborate with your multidisciplinary team colleagues, certainly regularly measure and provide feedback, and think about the type of rehabilitation environment that you are building. The other thing to keep in mind here again is the self-reported knee function outcomes. So here what you see are the COOs. We talked about the COOs a few slides ago. Self-reported knee function in pain, symptoms, activities of daily living, sports participation, and quality of life domains. They're the 5 domains that make up the COOs. What I've illustrated here on this graph are the average self-reported knee function results for each of those domains of the COOs, comparing patients who have had high quality rehabilitation program that you just saw on the last 2 slides to athletes or patients who have entered their data into the ACL registry and they haven't attended a high quality specialist rehabilitation program. And you see marked there in symptoms, in sport, and in quality of life, there is a clinically meaningful difference in self-reported knee function when we compare athletes who've received high quality rehabilitation to athletes who have received standard care. So it does make a difference at 2 years to how athletes perceive their knee function. It makes a difference what kind of treatment or what kind of rehabilitation they've received. And again, to remind you, if we're thinking about the belief that athletes have that I've got to rush and have surgery right away, prehabilitation, this period of intense rehabilitation before making a decision about surgery, that is part of a high quality rehabilitation program. The 4th and final belief that you might hear from athletes is that this idea that I've got to have surgery because the reconstruction will stabilize my knee and that's going to stop me getting osteoarthritis in the future. And unfortunately, the data do not bear this out. Having a reconstruction reconstructs the ligament. It might reduce some of the anterior-posterior translation of the knee, but probably the rehabilitation program that you're doing, the quadriceps strength, all of the other function and dynamic stability control in the knee is going to give more benefit than simply reconstructing the ligament. So the best quality data that we have, and this is a really recent systematic review, the results are quite variable because it depends on the patient population, it depends on the extent of the initial injury, depends on the extent of the treatment that was required to take care of those initial injuries in the knee. But somewhere between 1 in 10 and 8 in 10 patients with an ACL injury end up with symptoms and or radiographic osteoarthritis in future. And it doesn't seem to matter whether they have an ACL reconstruction or whether they have rehabilitation alone. You can see that the confidence interval of those estimates substantially overlaps. So we don't have strong enough evidence to say that having a reconstruction is going to help when it comes to preventing osteoarthritis. I'm going to talk a bit later on about what might have really important implications for developing osteoarthritis, but I'll come back to that. So I want to take the opportunity to let you pause for a moment here and consider what your treatment goals are for managing ACL injury. So I'm going to jump back as a refresher in the next slide and share with you the 3 goals that I shared at the top of our introduction. But take a moment to pause, consider the information that we've just been discussing, and think about what your 3 goals for treatment would be. So as a reminder, these were the 3 that I shared at the beginning of the session. So we really want to protect that meniscus. We want to do everything we can to promote recovery of quadriceps strength, and we want to do everything that we can to promote healthy sports participation across the lifespan. There are 3 key overarching treatment goals. There's going to be very specific treatment goals within those, but these are the overarching goals that we're trying to achieve when we're helping athletes make decisions about the best treatment for them after an ACL injury. So let's pick up on each of these. Treatment goal number 1, protect the meniscus. I shared before that there was some other issues going on in the research evidence about osteoarthritis. Here is what we suspect is going on. It's not the treatment itself that's making the difference to developing osteoarthritis, whether you have a reconstruction or you don't. It's the extent of the original injury to the knee. So what you see here quite clearly is that the prevalence of osteoarthritis after an ACL injury is quite different depending on whether the athlete has had or the patient has had an isolated ACL rupture, so not so much damage to the knee, versus a combined injury. So that might be a bone marrow lesion, it might be a meniscus tear, might be an articular cartilage lesion, as well as the ACL injury. So it's these associated injuries that really seem to make the big difference and have the strongest implications for developing osteoarthritis in the future. So this is really the evidence that's underlying our treatment goal of protecting the meniscus. Our treatment goal number 2 is about quadriceps strength. Now here I want to share some really compelling data that looks at the recovery of quadriceps strength symmetry comparing between 2 different rehabilitation programs. So you'll remember a few slides ago we talked about high quality rehabilitation and what high quality rehabilitation looks like. And here we see that high quality rehabilitation ends up promoting really strong or really good recovery of quadriceps strength. So 9 in every 10 athletes who receive high quality rehabilitation recover their quadriceps strength to at least 90% of the other side. Now we can talk about the limitations of limb symmetry. I'm going to park that and leave that discussion for another day, or perhaps the question and answer session. But bottom line here is that high quality rehabilitation is good at restoring quadriceps strength because it focuses on restoring quadriceps strength as one of its key principles. If you compare that to under treatment with rehabilitation, so by under treatment I mean that either these patients didn't do any rehabilitation or they did a very short, so less than 3 months rehabilitation program. They didn't do any neuromuscular jumping, landing, cutting, pivoting type of training exercise. It was a very short, very limited rehabilitation program, and you can see it makes a really big difference to the recovery of quadriceps strength. So here it's only 3 in every 10 athletes who are undertreated with rehabilitation restored their quadriceps strength symmetry to 90% of the uninjured side. We see similar results for recovery of hopping performance. Now, I appreciate that hopping performance is not simply a quadriceps strength function, it's a function task, but it does have some relationship to quads function. And importantly, we see a similar kind of pattern here in recovery as we did in the previous slide when we focused solely on quadriceps strength measured with a leg extension. So when we look at recovery of hopping symmetry, we see that of the patients or the athletes who received high quality rehabilitation, 8 in every 10 of them recover symmetrical hopping performance, only half of the athletes who are undertreated with rehabilitation recover symmetrical hopping performance. So again, the quality of the rehabilitation that you do really does make a difference to the function outcomes afterwards. Our third treatment goal, and we're going to come back to this a little bit later, is about injury-free participation. Now, we do have a problem with re-injuries after returning to sport after an ACL reconstruction or after an ACL injury. Now, these are data for ACL graft ruptures after returning to sport. These are professional soccer or football players. The key issue that we've got is that you can see the bulk of these injuries happen really early after returning to sport. So that's got some important implications for us as clinicians, making decisions or helping athletes to make decisions about timing of return to sport. So I'm going to, as I mentioned, I'm going to come back to this slide a little bit later on and talk about some of the tests that you might use, some of the implications that it has for your return to sport decision making and contributing to that return to sport decision making program. I also want to share, we've just spent a lot of time talking about high quality rehabilitation, and it probably doesn't surprise you to hear that high quality rehabilitation also seems to make a difference for the risk of new knee injuries after return to sport. So here again, you see the data for the athletes or the patients who have had high quality rehabilitation. The rate of new knee injuries after return to sport is substantially lower. So 1 in 10 versus 1 in 3, 3 in 10, I'm sorry, athletes or patients who'd been undertreated with rehabilitation. So I cannot underscore enough, the quality of your rehabilitation program really does make a difference for function and re-injury outcomes after an ACL injury. So my respectful suggestions for your rehabilitation planning is to start as early as you can to help ensure appropriate loading, facilitate tissue recovery and tissue healing. So that is facilitating the incorporation of the ACL graft if we're talking about athletes who have had an ACL reconstruction. It's also about recovery of the muscle and the other structures around the knee that are going to help with that dynamic stability that we think is really important. Starting your rehabilitation early is also going to help you build that rapport relationship, help support athletes in their mental recovery and in feeling confident to return to sport. And again, part 2 of this series covers the confidence side of returning to sport. And importantly, starting as early as you can gives you the best chance to use your clinical reasoning, use your good knowledge of rehabilitation to help athletes have the best chance of success. So I reckon there are 6 key ingredients for successful ACL rehabilitation. We just talked about the first one, start as early as you can. Certainly think about building what you can do to help athletes build realistic expectations and help them maintain their motivation across what we know is a long rehabilitation program. And there's going to be a lot more on that in part 2 of this series. Use criterion-based progressions or focus on criterion-based progressions that are tailored to the athlete and the demands of the athlete's sport. We're going to talk more about that in a few slides' time. But equally, respect biology and think about how long it takes for that ACL graft to incorporate, for tissue healing to happen, for recovery of function to happen. And it can take, the best research evidence suggests that it takes up to 2 years. So that's a lot of what's behind this push to be careful about return to sport happening too early. High quality, appropriately challenging content. We've spent a lot of time talking about this, so I'm not going to go over that again. Regular feedback and assessment is also critical. If you're not measuring, you're guessing. So get yourself some good measurement tools. Be confident about measuring particularly quadriceps strength.